the floor is yours now. So could you introduce yourself and then start your presentation, please?
No problem. Everyone can hear me okay?
Yes, thank you.
Great. Hopefully my computer holds up. My name is Bram Rochwerg. I'm excited to be presenting on the practical platform webinar series around CORT E2, Rationale and Design, along with Lorenzo del Sorbo, who you will hear from in the second half of the presentation and is co-PI for this domain. I'm an adult intensivist based at McMaster University in Hamilton. And yeah, as I said, we're co-leading this. So we'll jump right in terms of conflicts. We will do a handover at about the halfway point. So when I hand over to Lorenzo, he'll introduce himself and share his conflicts at that time. I do work as a guideline methodologist or support a number of organizations with guideline development, including those that have addressed steroids and ARDS and CAP in the past. Vice Chair for Surviving Sepsis, co-lead for the CORT E2 domain I mentioned, but no financial conflicts of interest, which I think is important to mention. Listen, folks, I think everyone knows that ARDS is an inflammatory condition of the lungs, right? And this from a famous New England Journal review article looking at the underlying pathophysiology of ARDS, which is predominantly driven by upregulation of the pro-inflammatory cascade, an increase in cytokine release, TNF-alpha, IL-6, as well as activation of neutrophils, monocytes into the alveolar space that increase pus and fluid. Also, there's an element of, maybe if folks don't mind muting if I'm not asking a question. Thanks. I should mention if folks do have questions, I have the chat open, or if you want, put your hand up. Even if there's something really pressing along the way, we'll definitely make sure that we find time for questions at the end. Beyond inflammation, there's that whole thromboimmunomodulatory pathway, and an increase in inflammatory cytokines also leads to microvascular clotting, which contributes to the pathogenesis of ARDS as well. And so, given the fact that so much of this is inflammation-driven, perhaps unsurprising that investigators have looked at the role of corticosteroids in the setting of ARDS in the past. And this was actually my first interaction or foray into the world of whether corticosteroids could be beneficial for patients with ARDS, and was fortunate. I mentioned that I worked as methodologist for a number of clinical practice guidelines in the past. And this was one of the first guidelines that I participated in with the Society of Critical Care Medicine and the European Society, in which we addressed a whole host of conditions, one of which was ARDS. And we made a conditional recommendation for giving corticosteroids to patients with moderate to severe ARDS, PF ratio less than 200 early in the onset of disease. And the reason we made this as a conditional recommendation as opposed to stronger is that we recognized that there was ongoing imprecision, lacked sort of one big randomized control trial. And in fact, a lot of the trials that had been done looking at the role of corticosteroids, despite the good pathophysiologic rationale, were small randomized control trials. The majority of them single center. Actually, the majority of them done by one guy, Umberto Meduri, who many of you might be familiar with the name, now practices in the United States. And so I'd say since that guideline got published in 2017, two big things, maybe a couple other smaller things, but two big things have happened. One, the DEXA ARDS trial was published in Lancet Respiratory Medicine, and we'll jump into a little bit more detail around that. And then two, this little sucker down there, COVID-19 and the pandemic that we're all familiar with, and an increased use of corticosteroids for folks with acute hypoxemic respiratory failure. When it comes to DEXA ARDS, I told you the criticisms of the data, at least in the past, had been that we did not have one big RCT looking at this intervention. And this is the idea. DEXA ARDS was to overcome this ongoing limitation. It was a multi-center RCT done in 17 ICUs across Spain, randomized almost 300 patients with ARDS based on Berlin criteria and a PF ratio less than 200. And they used a regime which those that are familiar with CORT E2 might look very familiar. Dexamethasone 20 milligrams for 5 days, and then 10 milligrams for subsequent 5 days for a total 10-day course of therapy. The primary endpoint in DEXA ARDS was ventilator-free days. And lo and behold, that effect that was seen in those small randomized control trials, the mostly single center ones, was seen now in a larger randomized control trial. You can see that ventilator-free days at day 28. Remember, when we talk about VFDs, more is better. So 12 VFDs in the dexamethasone group, versus 7.5 in the control group. You can see that translated into almost a 5-day difference and a statistically significant increase in ventilator-free days in the corticosteroid arm. Not just the primary outcome of VFDs, but you can see benefit in other outcomes like mortality at multiple endpoints, duration of mechanical ventilation, and not a huge impact on some of those adverse effects and complications that we commonly ascribe to corticosteroids like hyperglycemia, new infections, and barotrauma. I told you there was 2 big things that have changed in the last few years, and in addition to DEX-ARDS, probably the other big thing was COVID. And hard to imagine those first few days now of the COVID pandemic where we literally had no interventions. I mean, we now have a few options when it comes to, not that we see them anymore, but severely ill COVID patients in the ICU. And this was from September 2nd, 2020, a tweet from JAMA propagating their new meta-analysis that incorporated recovery data showing the benefit of corticosteroids in patients with COVID-19. Still pretty unbelievable that the pandemic started in February, and by September 2nd, we had a meta-analysis of randomized controlled trials demonstrating the benefit of corticosteroids. And this is the forest plot looking at mortality from that. You can see that recovery everyone remembers as being the big trial that informed this, and it was certainly the largest. But you can see that there were a number of other randomized control trials, Cape COVID, COVID steroid, Remap-Cap, that used varying corticosteroids, not all DEX. Some of them used hydrocortisone, some of them used methylprednisone. But for those that are familiar with looking at forest plots, a very consistent reduction in mortality. You can see almost all of those point estimates on the side of benefit, suggesting that patients with COVID-19 do better with steroids than without. This led to a subsequent WHO guideline that I was fortunate to help with through the pandemic. This was the first iteration of this guideline. Can you believe that we're on the 16th iteration right now of this? We just dealt with heparin, actually, and it's going to be published soon. But I don't think any of us imagined 5 years ago that we would still be working on this 5 years later and on the 16th version of the guideline. But this was the first in which we made a strong recommendation for giving corticosteroids to patients with COVID-induced respiratory failure. And listen, Bram's wrong about a lot of things. I don't know why I've suddenly referred to myself in the third person, but I'm wrong about lots of things. But I was giving steroids in the summer of 2020 to patients with COVID-19. And the reason I was is because when you think about the pathophysiology of COVID-19 induced respiratory failure, this figure hopefully looks very similar to that New England Journal figure that I showed you before, is that it's still upregulation of the inflammatory cascade. It almost doesn't matter what the underlying result is, and we see that with ARDS, is that whatever triggers the inflammation, viral, bacterial, contact, smoke inhalation, drugs, trauma, is that it's this dysregulated immune function that leads to a lot of the organ dysfunction that we see in the setting of ARDS. And Depayan Chowdhury, who was a master's student that was an intensivist, master's student, now practicing independently out at Mackenzie Health, also working a little bit at St. Joe's, led this systematic review meta-analysis where we used this hypothesis that steroids are probably going to have the same effect in patients with COVID or non-COVID ARDS, given the fact that they probably do have this shared physiology. And we showed that in fact, exactly that whether it's COVID-19 using ARDS criteria, whether it's COVID-19 requiring IMV, because a lot of those COVID-19 trials didn't specifically identify patients that met ARDS criteria. So we sort of use COVID-19 requiring IMV as a surrogate for ARDS versus non-COVID ARDS. You can see a consistent signal that across these populations, using corticosteroids leads to a reduction in mortality. I showed, this is from that systematic review, I showed you the mortality data based on moderate certainty evidence, duration of invasive mechanical ventilation, hospital length of stay, both lower with corticosteroids, but based on low certainty of evidence. We looked at a whole host of subgroups because a lot of people wonder, you know, oh man, the COVID studies use DEX. Is that what I need to use? Cape Cod, which we'll talk about in a moment, used hydrocortisone. Is that what I need to use? And in fact, probably doesn't matter what steroid you use. We looked across subgroup analysis across different molecules, and that benefit in terms of mortality was seen quite consistently. No signs of statistically significant effect modification. We looked at timing. We looked at dose, and I'll show you the fancy. If I had more time, I'd explain to you how this bubble plot and meta-regression works, but you'll have to take my word for it that there was no impact of dose. And, you know, Lorenzo is going to talk to you about the dose that we chose in CORT E2. It was a bit arbitrary, and it was a bit to align with Europeans that are doing a similar study and to align with DEXA ARDS, because as you can see, a horizontal regression line here suggests that, at least on the impact on mortality, dose didn't seem to really matter. The only subgroup that might have mattered was the duration of therapy. I told you we looked at a whole host of subgroups, and the only one that seemed to maybe show a signal for difference was duration of therapy. And you can see those that got greater than 7 days of corticosteroids for ARDS seemed to do better than those that got 7 days or less of corticosteroids. So maybe it doesn't matter what drug you use, it doesn't matter what dose you use, but maybe the duration piece is the one that matters. Now, all the normal caveats of subgroup analysis in terms of, you know, limitations, especially between studies here, but certainly hypothesis generating to say the least. I think another thing that folks often bring up is, what about the adverse effects? I'm trained as an internist. Maybe others on this call are also trained as internists. And, you know, we always think about all the bad stuff associated with corticosteroids that they, with good reason. And, you know, I think when you use it in an outpatient setting for months and months and months, we see a lot of problems associated with corticosteroid use. And so we wanted to summarize the harmful effects of corticosteroids in the acute setting. And we did so. Hold on. Team upstairs, I'm at home, is incredibly loud. 1 second. Hopefully it's not coming through. Send a angrily worried text upstairs. What we thought the viewpoint is that maybe the benefits of corticosteroids are disease specific, but harmful effects of corticosteroids probably transcend conditions. So whether you're using corticosteroids for CAP, for ARDS, for sepsis, again, those beneficial effects may be disease specific, but those harmful effects perhaps shared across these conditions. And this was the hypothesis Depine again used in summarizing the adverse effects across these conditions in this meta-analysis that we published in Critical Care Explorations. And we're able to show that there are certain adverse effects, GI bleeding, moderate certainty of no effect, super infections. Now, there's limitations. The investigators across these large number of randomized control trials did their best to capture these adverse effects, but I can't say that it was perfect. No impact on superinfections, maybe an increase in hyperglycemia and hypernatremia, both potentially important complications, but I would argue that if we're saving lives and reducing the duration of mechanical ventilation, that you know, these are treatable in a critical care setting and maybe not most important. The one that I am perhaps concerned about might be neuromuscular weakness, the fact that corticosteroids might increase neuromuscular weakness. More and more patients surviving critical illness, dealing with the morbidity associated with critical illness, and any intervention that we give that might have an impact on that. Folks like Margaret Herridge have shown the monumental impact that a duration spent in the ICU can have, and certainly a worrisome feature. Low certainty evidence is an outcome that's not systematically captured across many of these randomized control trials. I do see, Brent, your hand up. Maybe what I'll do is I'll just finish my part, which is not a ton left, and then we'll see if we want to do questions then or perhaps questions at the end. And so I think I've gotten across to you perhaps, you know, the potential benefits of corticosteroids in ARDS, however, an element of ongoing uncertainty. And, you know, even though it seems like now with DEXA ARDS and the indirect evidence from COVID that there's an inclination that patients with non-COVID acute hypoxemic respiratory failure might benefit from corticosteroids, practice still remains varied to some degree. And I'll show you a little bit of survey work that we did a couple of years ago. The other piece, I think the other ongoing big concern is, what is the optimal duration of therapy? And I know I struggled with this, and many that I've talked to also struggled with this during the pandemic. You'd have those COVID patients, you use the recovery 10 days, which is relatively arbitrary in itself. At the end of the 10 days, your patient's still super sick, still on the ventilator, still on high settings, maybe still on high flow. Do you stop the steroids at 10 days? Their x-ray still looks like crap. You know, there's still probably ongoing inflammation. Do you continue for 2 weeks, 20 days? I think a lot of, uncertainty about what the best approach is. And then we have that subgroup analysis from our meta-analysis to suggest that longer duration might do slightly better. You've perhaps sensed my careful speaking around ARDS versus acute hypoxemic respiratory failure. At least when we were crafting CORT E2, we intentionally moved away from ARDS to acute hypoxemic respiratory failure. Perhaps that actually transcends practical in general, is that we've moved away from ARDS. So a lot of the data I've shown you is specific to Berlin criteria ARDS, but I think we recognize that respiratory failure is a spectrum, right? And maybe you're still on high flow or NIV, which pre-global definition could not have met the definitions for ARDS, but you're still on this spectrum of severity of illness consistent with the construct of dysregulated lung inflammation. And in fact, maybe even earlier intervention with things that like corticosteroid might be more beneficial than waiting until you're mechanically ventilated and meeting ARDS criteria. Forget the fact that classic ARDS criteria requires bilateral airspace disease when we know that X-ray interpretation is nebulous at best, and two-zone infiltrate on the same side carries the same prognosis as two-zone infiltrate on contralateral side. So lots of limitations with using ARDS, and we successfully argued in our grant application that this construct of acute hypoxemic respiratory failure might be a good substitute for ARDS. And so, I wanted to show this one piece around, maybe as a quick side jaunt, an interesting piece, and only have a little bit longer before I hand it over to Lorenzo, was that when we submitted this initially for funding, one of the points of feedback we got was that we needed to do a better job defining current practice, demonstrating that equipoise persists. But for those that were on the domain committee, you might remember that the decision around the 2022 project grant and then the resubmission for the clinical trials fund was only separated by about 5 or 6 days. So, a timeline that was simply impossible to do a robust survey for. So I did what I knew how to do, and I went to Twitter and I did a Twitter poll around whether there's equipoise and what folks' current practice is around corticosteroids in the setting of COVID and non-COVID acute hypoxemic respiratory failure. And I actually included the results of this Twitter poll in our reapplication for CIHR, and we got funded on the second time. So I'm not saying it was just because of the Twitter poll, but a cool avenue where we were able to, capitalize on Twitter to inform a grant application that the reviewers at least felt was good enough that they didn't push back and they were still willing to fund. But interestingly, in question 1, you can see maybe quickly looking at these, I said COVID patient on mechanical ventilation, slow to improve, still on high vent settings. What do folks do? And the majority, at least then, said that they stopped steroids at the 10-day mark in a COVID patient, regardless of clinical status, which I thought was interesting, but only about, just greater than 50%. Patients with non-COVID acute hypoxemic respiratory failure do give steroids. Only, at least at this time in 2022, 19% said almost always, 34% said half the time, 47% said never. I wonder if that's shifted a little bit more towards wider adoption, given some of the CAP data that I'm going to show you in a moment. But at least interestingly, a couple of years ago when we submitted, most people do not routinely give corticosteroids, despite the data that I showed you, and demonstrating that I think there's an element of equipoise. Maybe folks don't believe that DEX-ARDS was done in 13 ICUs in one nation, right? And maybe there's still only 400 patients. Maybe there's still an element of equipoise out there that folks feel like the evidence base is not strong enough, given the uncertainty around harms as well. Patients with non-COVID acute hypoxemic respiratory failure on high flow or NIV. So these would be the ones that wouldn't quite meet ARDS criteria that we're including in CORT E2. Do you give steroids? And only 8% said almost always, 22% said half the time, and a vast majority, 70%, said almost never. And, even in this era of folks using more and more steroids, I've been certainly, Lorenzo and I both been advocating that maybe it's these ones on high flow NIV that meet eligibility criteria that were even more, perhaps have an element of equipoise for randomizing. Question 4 and 5 were both asking if you'd be willing to randomize a patient in either what turned out to be the early cohort and the extended cohort, and a high majority, greater than 80%, said that they would be willing, enough equipoise that they'd be willing to randomize. Lastly, before I hand things over, I wanted to talk a little bit more about CAP, because this is probably the area where we've had the most amount of incremental evidence in the last couple of years. we think it's all the last couple of years, but a colleague of mine, Reid Semeniuk, actually published this meta-analysis in Annals of Internal Medicine back in 2015, which included 12 trials and showed almost a statistically significant reduction in mortality. Although using grade language, we would say probably a reduction in mortality, given that upper end of the confidence interval that just crosses 1. And reduction in the need for invasive mechanical ventilation, a reduction in ARDS. Again, perhaps this meta-analysis suffered from the fact that it was mostly small randomized control trials. More recently, many are familiar with the Cape Cod trial published in New England Journal in 2023, showed a statistically significant reduction in mortality, their primary outcome, mortality at day 28, with those that got randomized to hydrocortisone. Again, probably pneumonia is an inflammatory condition of the lung, and giving corticosteroids helps quell that inflammatory response. And I know Lorenzo and I sweated it out a little bit when this came out, thinking what's the implications that this is going to have on our ability to enroll patients in the early cohort that he's going to talk about soon. However, even more recently, REMAP-CAP corticosteroid published just in the last few months, which did not show the same benefit of hydrocortisone in folks with severe CAP, and maybe even a small signal for harm. In fact, those that got hydrocortisone, you can see, had a slightly lower probability of survival compared to those that didn't. So I don't know where this leaves us. I think that I do tend to, I'll be honest, tend to use corticosteroids in those with severe CAP. But equipoise persists in my mind. And if somebody came to me and said, yeah, sure, you usually use it, but would you be willing to randomize this patient? The majority of the time, I probably would, especially those folks that are still on high flow, on NIV, that don't quite meet ARDS criteria. And, maybe CAP is one thing, but what about those with HAP or VAP or aspiration that weren't included in studies like Cape Cod, and that weren't included in studies like REMAP and all the other small trials that have looked at community-acquired pneumonia? And we're certainly still interested in that population, as Lorenzo will tell you, in CORT E2. So, let's say folks are even using more corticosteroids for community-acquired pneumonia, given the Cape Cod results, but inconsistent with the REMAP corticosteroid results. Again, there's still a large population of patients with acute hypoxemic respiratory failure that we are interested in, and that I think that there is still a huge degree of equipoise, even if you don't think that there's equipoise in severe CAP, which I wonder if there still is, especially in certain subpopulations. And for those sites that are enrolling in CORT E2, again, Lorenzo is going to jump into more details, but if more patients are getting upfront corticosteroids, that should increase the pool of patients that are eligible for what we call the extended cohort. And that'll make more sense for those that haven't seen it shortly. Lastly, I skipped over this, but a quick plug. In addition to REMAP corticosteroid that just got published, we actually updated the meta-analysis looking at corticosteroids for non-viral CAP. If you want to check it out, cite it for your work if it's relevant in intensive care medicine. This is only published a few weeks ago. And you can see that benefit, even when you include all the trials, REMAP-CAP, a small drop in the bucket compared to now rapidly accumulating number of randomized control trials. And again, a signal for benefit, moderate certainty, reduction in mortality with corticosteroids in severe CAP. And on that note, I will stop sharing if I can figure out how to do it on my computer. And I don't know, maybe while Lorenzo's sharing, Brent, I don't know if you have a question, but I'm happy to address while he is.
Sure, thanks, Bram. So as a scientist, my first question is, okay, if there is a benefit, show me the mechanism. And if you truly believe in the hypothesis of sort of cytokines and inflammation, I don't believe, now I could be wrong, that there is any firm data on at least classical cytokines showing there's a benefit. So I think there's a big hole there, quite frankly. So when we looked at COVID, and what's very interesting is we compared Delta and Omicron and those that got steroids, there was a differential response in the inflammatory metabolites. And so it showed that there was much more benefit with Delta than Omicron. So I wonder if you can see that in the cases in some of your analyses.
I will give you, Brent, thank you. I will give you my perspective, and I'm keen to hear Lorenzo's because this is his area, his baby, and his area of interest as well. Is that I think, the heterogeneity of treatment effect is a huge consideration here. And I'm sure there are folks that within our population that meet our eligibility criteria that might benefit and folks that will not. And I think you're right. We don't yet know how to identify those folks. Because if we did, we would use predictive enrichment and only really focus in on those that we would enroll that we think will benefit. And so Lorenzo has built in a translational sub-study here where we're collecting biosamples in order to hopefully be able to contribute to further explaining at a pathophysiologic level the upregulation, downregulation of inflammatory mediators and how we might be able to predict in the future those that are going to respond to therapy versus those that aren't. Lorenzo, I don't know if that makes sense or if you have other stuff to add. I'm sure you do.
It makes lots of sense. And just to highlight, as Brent is part of that group of translational biology that is trying to answer this question. So that's, I think, is very interested in the topic for that specific
Yeah,
reason.
I think, and I actually think metabolomics may be very useful in identifying those at high risk.
Yeah, I completely agree. And yeah, we could use metabolomics or proteomics or the measurement of cytokines, not only to identify patients that may benefit the most, heterogeneity of treatment effect, but also the ones that may respond, like using biomarkers as a early marker of treatment effect to avoid, if we can show that we can identify in that way also patient may not respond to treatment and avoid the prolongation of the ineffective treatment. So that
But
I
Lorenzo, to date, I'm not sure the cytokines back up that inflammatory just from a pure cytokine point of view.
think
And I don't know if you can show me an analysis that would argue with that. But if you look at all the data over time, it's very mixed and there isn't a clear signal to my knowledge.
I completely agree. But most of the papers though have only one time point cytokines measurement, and so that's why we set out to measure it over time. So maybe the effect is not only on one time point. But you're completely right. The effect on cytokines or the role of cytokines in the mechanism mediated by corticosteroids is very nebulous. I agree. Okay, if there's no other question, I'll continue. So Lorenzo, my name is Lorenzo Sorbo. I'm an intensivist at UHN, Toronto General Hospital, and I had the pleasure to work with Bram Rochwerg in leading this fantastic CORT E2 study. And I have interest in translational biology, science as well, as you heard. And in the next few minutes, I'll present the trial, the design of the CORT E2 trial. So corticosteroids early and extended randomized control trial. I'm co-PI in this trial. I don't have any financial conflict of interest. And this is a domain within the practical platform. Okay, so we're happy to participate in this nice experience and task. So this is a phase 3 multi-center Bayesian RCT embedded, as I said, in the practical platform that we want to roll out in 30 sites in Canada, and we're planning potentially to expand out of the borders in other countries to optimize recruitment rate. And is designed with 2 cohorts, and I'll explain that in the next few slides to inform clinical practice and address really the 2 knowledge gap that Bram nicely outlined in his presentation in COVID and non-COVID respiratory failure. So the early cohort will test if early corticosteroids in non-COVID ARDS are the efficacy of early corticosteroids in non-COVID ARDS, and in the extended cohort will test the efficacy of extended use of corticosteroids in persisting acute hypoxemic respiratory failure due to COVID or non-COVID at this time. So the research question is, in patients with non-COVID acute hypoxemic respiratory failure that require high flow nasal cannula, non-invasive ventilation, invasive ventilation, or extracorporeal life support, what is the effect of 10 days of dexamethasone compared to no steroids, no dexamethasone on 60 days mortality? In the extended cohort, instead, we were asking if whether in patient with acute hypoxemic respiratory failure of any etiology, so at this point COVID or non-COVID, who have been treated with at least 10 days of corticosteroids and has still ongoing requirement of high flow nasal cannula, again, non-invasive ventilation, invasive ventilation, or ECMO, what is the effect of extending therapy for another 10 days, and then including a taper for a total of 25 days compared to stopping that dexamethasone on the primary endpoint, which is 60 days mortality. And of course, our hypothesis that in both early and extended cohort, steroids will be beneficial. The primary outcome, as I said, is 60 days mortality. We'll have a list of secondary outcome, patient center, mortality at any other endpoints, hospital length of stay, duration of non-invasive ventilation or supplemental oxygen, need for ECMO, duration for ECMO, ventilator-free days, sensor at day 30, and health-related quality of life at 6 months, given the potential complications related to steroids use, and other complication side effect of unwanted side effect of corticosteroids that Bram nicely described, in particular hypernatremia, hyperglycemia, delirium, GI bleed, infection, and neuromuscular weakness. Sample size, so is a Bayesian set study, so there's no fixed sample size, and this will be evaluated using a Bayesian hierarchical statistical model. And so we will continue to enroll till the statistical triggers, which we define in the protocol, we define superiority, inferiority, or equivalence. And but the maximum sample size that we calculate is 2,000 patients. And I think we have a minimum sample size for the first interim analysis of 750. The randomization will follow a one-to-one scheme, intervention versus control, stratified by study centers and oxygen and level of oxygen support, in particular non-invasive versus invasive or ECLS at time of randomization. So this is the scheme of the study. So patient with on the top, patient with acute hypoxemic respiratory failure that are not receiving corticosteroids for acute hypoxemia, of course, for this indication, can be randomized in the early cohort to dexamethasone 20 milligrams for 5 days, and followed by 5 days of dexamethasone at 10 milligrams, which replicates really the DEXA ARDS study and other ongoing investigations done in Europe, GARD study, GARD trial, and other trial in the RIMACAP, and or randomized to usual care without steroids. If the patient with admitted with acute hypoxemic respiratory failure has been ordered steroids, either because they had COVID or because of the Cape Cod, or maybe the attending physician was adamant to use steroids for septic shock related to respiratory failure, and the patient is receiving steroids for 10 days, it becomes potentially eligible at 10 days for the extended cohort. So at 10 days, patients that still require high flow nasal cannula, non-invasive ventilation, invasive ventilation, or ECMO can be re-randomized, okay, to extend the course, so to the intervention arm, which includes dexamethasone with 10 milligrams for another 10 days, and then a taper of 5 milligrams for another 5 days, and then stop. So with the possibility of receiving steroids for a total of 25 days, or usual care, which would mandate stopping dexamethasone at day 10. If the patient, after 10 days from the early cohort or receiving steroids for any other indication, are recovered and don't meet criteria, don't require oxygen support or invasive or ventilation support or ECMO support, then they will not be randomized, not meeting the inclusion criteria for the extended cohort. So we'll enroll patients enroll that meets the criteria for the practical platform, and the practical platform will always stratify patient in 4 strata: non-intubated patient on high-flow nasal cannula, non-invasive ventilation, intubated patient with low elastance, intubated patient with high elastance, and patient on extracorporeal life support. For the purpose of our domain, in the CORT E2 study, we won't measure and stratify patient according to elastance, but rather have a stratification of patient non-intubated versus patient intubated or on ECLS. We want the inclusion criteria for the early cohort includes patient admitted to an ICU within 72 hours, okay, with unilateral bilateral space disease confirmed by some imaging. And there are exclusion criteria. So if the oxygen support is with low flow oxygen therapy, less or equal than 15 liters per minute, patients are excluded. If they receive more than 2 doses of corticosteroids during the previous 14 days, or if they have existing indication for steroids or high suspicion or confirmed infection with the COVID, or if the patient had acute traumatic brain injury during the index hospital admission or allergy to dexamethasone. So these would be exclusion criteria for the early cohort. The extended cohort inclusion criteria: patient needs to be still admitted to the ICU, have already received the 10 days of steroids for acute respiratory failure, and either randomized to the early cohort of the CORT E2 study, patient with COVID, or patient that have received steroids, like, for example, with according to the Cape Cod schema for pneumonia, for other acute hypoxemic respiratory failure causes. And there needs to be an ongoing requirement of high-flow nasal cannula, non-invasive ventilation, or invasive ventilation or ECMO. The exclusion criteria is an alternate for the extended cohort, again, alternate indication for ongoing steroids and acute traumatic brain injury in this admission. This is a summary of the treatment that I mentioned already. For the early cohort, patient will receive 10 milligrams of 20 milligrams of dexamethasone for the first 5 days, followed by 5 days of 10 milligrams. And the control group will have no steroids. In the extended cohort, again, the patient will receive additional 10 days of dexamethasone 10 milligrams, followed by 5 days of taper with 5 milligrams of dexamethasone. And the control arm will receive no steroids and no taper. We'll have follow-up, as I said, 60 days to assess vital status, and 6 months for the questionnaire related to health-related quality of life. And open for question.
Thanks, Lorenzo. That was great. The only other thing I was going to update folks on, I think, do you remember the exact number where we're sitting at right now? 30 active sites, and I want to say 100 and something randomized. I was just pulling up the exact number.
Yeah. Sorry. I didn't mention that.
167, I think I see. 30 sites, 167 randomized.
Which is, we have to say, maybe a little bit lower than the recruitment rate that we would expect from the 30 sites. But yeah, still hopeful. Yeah. Brent?
Do you have planned and funded molecular studies that you could talk about?
Yeah, so Brent, we apply several times to CIHR with the question, and it's been declined several times. So we're waiting for the result of the spring call in hopefully soon. Yeah.
Thanks.
But this is I think it's very important. And we really targeted the CORT E2 trial and also the IMV in the IMV domain, the DRIVE trial, driving pressures versus the target mechanical ventilation versus volume control, with specific scientific question. So one is to study heterogeneity of treatment effect, see if that's based on the already published subphenotype by Caroline Calfee and is a fantastic group, and then to see if we can identify markers or other, we're going to run another for sure latent class analysis with the data that we have and see if we can describe heterogeneous treatment effect with other markers, and then to understand if there is any marker of a treatment response, early marker of treatment response. And for sure, Brent, we ask your help with that to investigate if metabolomics may be a better way to analyze those samples.
Okay, thank you so much for your presentations. I think we still have some time, so if you have any other questions, can you just raise or speak up?
Maybe while folks are thinking, the other maybe thing to pass along as well is the Brits, Danny McCauley and Manu Shankar-Hari, are working on a similar trial in the UK. And so we've had lots of discussion with them about how we interact and share data and inform the DSMB. And we've aligned with them, for those that are aware, they're randomizing right now too, and at a fairly similar stage. So we've aligned primary outcome, we've aligned data collection, thinking ahead. There's obviously a spectrum. We're very inclined to collaborate as best we can, but there's at the very least IPDMA trial level meta-analysis, but still in discussion about how much integration we do.
Thank you for your information.
One Iraqi or Bram, if I may, so one difference, Bram, if you want to mention the GARD trial compared to the CORT E2 is the control group. That I think in the GARD trial they allow for they include patients even if they are on steroids for any other indications. So we discussed at length if that was a good choice or not. I don't know if anyone here has a strong opinion in favor or against. We like with Bram, we like nice clean experiments. So I think achieving a difference in between treatment and control in terms of steroid exposure is key, but the GARD investigators felt definitely different.
I see. Thank you so much. Yeah, I think if my memory is correct, I think. Sorry, Brent, if you have any additional comment, thank you.
Yeah. So for some of the omics studies, you may need to match by age and sex, because those will be defined by the omics that you use. So you have to have enough controls dispersed over the age group so that you have appropriate age-matched controls.
Yeah.
If you're going to make sense of some of the omics data.
Yeah.
So just a suggestion.
Okay. We'll see what the trial brings, because unfortunately, I know we can discuss, but the collection of biosamples, in particular blood samples, is optional, and so we'll see the distribution of the participant in that task. Yeah.
Okay. Any other comments, questions? Yeah. Can you just raise hands? Okay. Maybe I have one question. I think if my memory is correct, I think CAP called
Yeah.
But I wonder if you may miss some potential patients who might have got only shorter time of steroid. I wonder if you have any thoughts on that.
Yeah, we had. Thank you, Iraqi, to bringing up this fantastic point. We had a lot of conversations. So, in fact, we allowed inclusion in the extended cohort for patients that receive at least 8 days, 8 to 12 days of steroids. This to accommodate several things, including the termination of early cohort, for example, during the weekend. So we don't want to miss, so we allow 48 hours of buffer for that reason. And that should encourage patients or physicians that are prescribing steroids for septic shock with, of course, acute respiratory failure as well, to complete the course of hydrocortisone as prescribed in all the trial investigating the role of hydrocortisone in septic shock for at least 7 to 8 days, and not to cut it short, because the common practice is to stop the steroids as the patient comes off pressors, which reduces the duration, and that really compromises the eligibility. Further reduces the duration maybe to 3-4 days, and that would really compromise eligibility for the extended cohort, which instead, as Bram very nicely showed and presented today, showing his meta-analysis, a burning question, should we extend the duration if the patient has still seen, of course, criteria to be eligible for the extended cohort or not.
And as Lorenzo says, from Cape Cod, the duration of therapy was 8 days for those getting better and 14 days for those not getting better. So, and as we know, recovery was 10 days. And DEXA ARDS, if you believe in it, was 10 days. So there's not a lot of data supporting anything shorter than 8 days if you're using it for respiratory failure, to be honest.
Yeah, I think thank you so much for your clarification. That makes more sense to me. Yeah, and another question, I think people talk about the duration of therapy. Bram, you mentioned the duration of steroid is kind of arbitrary. But like, can you give us some more clarification? Why did you chose like a 10-day of Dex 10 milligram and 10 additional 10 days plus 5 milligram 5 days? How did you come up with this intervention?
Yeah, we had, Hiroki, lots of discussion. Maybe Lorenzo has other thoughts afterwards too. We had lots of discussion about that early cohort regime and the extended cohort regime, because as I've shown, like, it doesn't seem to matter what drug you use, what dose you use, maybe duration matters. And so why do we pick Dex 20 milligrams? Like, I'll be honest, we considered like a 3-arm or a 4-arm trial with different, but quickly that becomes impractical and not feasible to do a multi-arm trial. And so we had to land on something. You could make the argument, why not use the lowest dose possible then, if it doesn't seem like higher doses matter and maybe you can avoid side effects. That being said, we had DEXA ARDS is the best data that we had going into this in the acute hypoxemic respiratory failure ARDS population. So we figured we would kick ourselves if we used a lower dose and weren't able to reproduce the same in a larger trial, the same results that we're seeing in DEXA ARDS. And we had long discussion with the UK, the Brit group as well, that's doing a similar trial. And in the long run, we decided let's stick to DEXA ARDS, to the same regime, the 10 days, 20 milligrams for 5, 10 milligrams per 5, increase our likelihood of showing a benefit if we can reproduce the results from there, and then facilitate the same intervention that they're doing as well for pooling in the long run.
Yeah, and then also, if I may add, after, if the patient is included in the extended cohort and randomized in the intervention group and exposed to 20 days of steroids, we thought that of dexamethasone, we thought that after 20 days, maybe a taper was a safer way to treat this patient. So that's why we added 5 days of 5 milligrams, if the patient still requires ICU, of course.
Thank you so much. Yeah, this is $1 million question, and clinical ECPO is quite important. I think we have a couple more minutes. Do you have, if any of you have any other questions, can you raise your hand or speak up? Okay. I don't see any hands up or any comments in the chat.
I'll put my email in the chat. I'm sure Lorenzo doesn't mind as well, in case folks do have questions and want to follow up.
Okay. Yeah, thank you so much. Yeah, it's great. And then, you already enrolled more than 160 patients, so it's up and running. And thank you so much for the update as well, and then all the detailed protocol explanation, rationale behind. Kathy, do you have any other announcements?
Yeah, thank you, Bram and Lorenzo, for the informative presentation. And thank you all for attending today's webinar. The next webinar is scheduled on July 9th. There will be more information circulated later on. Thank you.
Okay, with that,
thank you, everyone.
Thank you.
Thank you so much.
Thank you.
Good night.
Bye. Have a good night and evening.